Hello, Dallas. Good evening. My name is Mary McCarty-Arias, and I will be your trainer for the next hour. It's really a delight to be here. I know that I can't see you and I can't hear you, but I hopefully will get to you writing in some questions pretty soon. Let me just say that I'm really honored to be here. In March, I went to Dallas and I did 2 days of training at the bridge. And I was so blown away by how nice everybody was and how competent. And then during lunch on the second day, I walked over to the bridge with Natisha and Sarah and was just so taken aback by how beautiful your site was. And I was thinking, gosh, why can't we have that in New York City? So it's really great to be here. I have to say, too, that one of my favorite lines on day 2 when I was training, and I know that a lot of people were mandated to the training. I was going around and people were saying their name, and they were also saying what they did and what they wanted to learn. And I told people that if they wanted to say they were mandated, they could. And one of my security guards said, "I'm only here so I won't be fined." As some of you who are, oh, I see that you are still having a couple of people walking in. Okay. That's okay. I'm going to keep talking. We're just really at the beginning, and we haven't gotten to some of the material yet. I was just actually quoting Marshawn Lynch, so for those of you who are sports fans or football players, one of your security guards gave him the answer. So while I was here, while I was there, I've been studying more about Texas, and I know that everything is bigger in Texas. One of the things I learned today is that when the roof is closed of the Cowboys Stadium, the entire Statue of Liberty could fit into it. So that may be more than you needed to know. And also, I was thinking about the television show Dallas. Now, what does that have to do with co-occurring disorders? Actually, it does, because one of the main characters, Sue Ellen, had a co-occurring disorder. They didn't call it co-occurring disorder at the time, but she was dealing with alcohol use disorder and also depression. And the actor who played J.R. Ewing in real life, Larry Hagman, struggled with alcoholism and later in his life had a liver transplant and eventually died probably as a result of alcoholism. So that's some of the tidbits as people are still walking in. Let's get started. So there's my picture. As I said, my name is Mary McCarty-Arias, and I'm here at NDRI in New York City. And I started in the field working as a vocational rehabilitation counselor and worked in drug treatment, and at the same time worked with people with co-occurring disorders. So that is some of what I've been teaching for many years. I can tell you I'm not wearing that sweater. It's about 93 degrees in New York City, but glad to see you. So let's get started with what we're going to do today. This really is a basic course, and 2 of the goals are to increase your knowledge about co-occurring disorders, substance use disorder, and mental illness. So it's really those 2 disorders, and we'll talk about what they are. Some of you are familiar with some of these, and we'll look also at some of the new diagnoses with the DSM-5. We'll also look and probably discuss your roles in working with people with co-occurring disorders, so that I know that some of you will be diagnosing or maybe referring. I think one of the gifts that some of you who are the security guards have is you really get to know people in a different way, and you'll probably be seeing some of the red flags that people have and can work closely with some of the other workers. So let's look at some statistics, and one of the first things we'll talk about is SAMHSA. SAMHSA stands for Substance Abuse and Mental Health Services Administration, and one of the things that they do is they provide a lot of information on co-occurring disorders, on trauma. All you have to do is really Google them and get a lot of information. And when you look at some of the statistics on people with mental illness and substance abuse, this is what they said. And they also looked at, for example, people who are homeless. So they said that 60% of people who are homeless have experienced a mental health problem in their lifetime. In addition, they said that 80% of people who are homeless have experienced alcohol and other drug problems. I was looking on your website a few weeks ago, and according to your website, it said that about 80% of your guests, and I know you do use the term guests, have co-occurring disorders of substance use and mental illness. Do you agree with that? Would you say about 80% of your people have co-occurring disorders? Great, thanks for answering yes. So here's another question, and I'm going to ask you to write in, what are some of the substances that your clients or that your guests are using? What are some of the substances that people are using? Okay, two. Yeah, that's a big problem in New York as well. Cocaine. How about heroin? Oh, drinking, definitely. Meth, methamphetamines. Alcohol? Of course. Okay, so there's a variety of substances. How about in terms of some of the mental health diagnoses that you know about? What are some of the ones that you see or maybe see on a chart or think that people have? Probably all of the above, right? So people with bipolar disorder, schizophrenia, a mental retardation, which is one of the developmental disabilities, and depression. And so, as you can see, and I know from some of the clients that I met at your site, you're dealing with a lot of the kind of common combinations. One of the most common combinations is depression and alcohol use. Bipolar disorder is also common with cocaine, and people with schizophrenia often are using medications like marijuana and alcohol. So you kind of hit the whole gamut of some of the co-occurring disorders. So let's look then at what is the definition of a co-occurring disorder. And this is taken from SAMHSA as well, and basically it's a simple definition, and it talks about you have to have one or more disorders related to the use of alcohol and other drugs of abuse, and one or more mental disorders. And that's the working definition. And the key is often that they have to be established independently of the other. Why do you think, actually if you were in person I'd ask you more questions, but some of this I may tell you some of the answers, because if you look at some of the topics or some of the terminology that's been used, some of you remember when people would use the term MICA, mentally ill chemical abuser, or CAMI, chemically abusing mentally ill, and sometimes those terms were used to look at maybe what came first. One of the things that we look at with co-occurring is many of your clients have not just 1+1, but 2 substance use disorders. Some of them have 2 or 3 mental disorders. So it may be common to have alcohol use disorder, cocaine use disorder, as well as depression or post-traumatic stress disorder or personality disorder. So sometimes people will have up to 5 diagnoses. The key is, again, they have to be established independently of one another. One of the things that they have in common, by the way, when you look at, oh, why does substance use and mental illness go together? Some of the common factors that they have are brain chemistry. You know, we talk a lot about challenges with brain chemistry. There are some of the things that we know about mental disorders. Also genetics, so that substance use runs in families, and also many of the mental disorders also run in families. So there's a strong genetic component to depression, to schizophrenia, to bipolar disorder, and actually almost to all of them. And in addition, there's also high stigma for both of these disorders. People always blame you for getting them, and sometimes people think that it's really easy to fix them. You know, when people talk about substance use and just say no, or if just say no worked, many of us wouldn't have jobs, and you probably wouldn't have as much work as you do. I remember working with a nurse who, and this was in a psychiatric hospital, she didn't understand depression too much, and she went up to a client who was in bed and she started like clapping her hands. and she kept saying to him, wake up, snap out of it. And she thought that by doing that, that would cure his depression. Unfortunately, that didn't work. A couple of things around gender, by the way, is often men, if you ask men what diagnosis they have, they like to say that they have substance abuse as their diagnosis. Women tend to say that they have mental health. Adolescents prefer to tell people that they're in rehab for a substance. However, their parents often like to tell their friends that they are dealing with mental health. So what are some of the advances in the treatment of co-occurring disorders? Some of the things, and this comes from Tip 42, which is called Substance Abuse Treatment for Persons with Co-Occurring Disorders. These are free books, by the way, that you can get from SAMHSA, that you can actually call for to get, or you can download them. And these are some of the things that they talked about. One is they say that there's something called the no wrong door policy. And what they mean by that is when somebody comes into a treatment program, that they are accepted, that they are seen, and maybe they'll be referred to another place. But I remember in the old school, when I first started in the field, if you went into a psychiatric hospital and you started talking about using drugs, guess what they said? Goodbye, I think you need to go to another place. And if you went into drug treatment and started talking about hearing voices, the response you often got was, sorry, we can't take care of you here. And I know from being at the bridge for those 2 days that many people, there is no wrong door, and that many people are welcome at your site. Another one is mutual self-help, and those are 12-step programs for people with co-occurring disorders. I'm not sure if they have any in Dallas. Do you know if they have any in Dallas? They're called Double Trouble, and they were actually an evidence-based practice for co-occurring disorders. There was a researcher, by the way, his name was Howie Vogel. He used to work here at NDRI, and when he was doing the research, he called it double trouble. Now, a lot of people don't like that because they feel that if they're going to a double trouble meeting, that there is like a bad feeling about that, but because he did the research on that, he can't really change the name. Another piece is integrated care, and many of you are familiar with that, and also development of effective approaches. So I remember when Paul recently did the course in motivational interviewing, that is one of the evidence-based practices for people with co-occurring disorders, as well as people with substance use disorder. And evidence-based practice is really just a fancy term for it works, or there's been research that shows that it works. So there have been a lot more approaches, and that's been really helpful for people with co-occurring disorders. Finally, on that slide, there have been a lot of pharmacological advances. There have been advances for substance use. So we've had methadone for a really long time, but sometimes people are now using buprenorphine. They're using Vivitrol. And some of the new medications that people are taking for mental illness have less side effects. So there's one of my favorite books. I know that sounds corny, but this is the new DSM-5, the Diagnostic and Statistical Manual of Mental Disorders. And this came out in 2013. It's not in the public domain, by the way, so I just definitely wanted to source it. And when it came out, it changed some of the disorders and even changed some of the names that we talked about around substance use disorders. One of the reasons why there's a new DSM is that every so often there's new technologies and brain scans, PET scans, CAT scans, and they can look at a person's brain and get a lot more information than they could 10 or 20 years ago. So it's a new way of looking at the disorders. By the way, they changed the DSM-5. Remember, it used to be a Roman numeral. It was the DSM-4IV-TR, and TR meant text revised. And now what they do, because of different kinds of word processors, as we speak, they're redoing it again, and the next one will be called a DSM 5.1, followed by DSM 5.2. So that's just something about the Diagnostic and Statistical Manual of Mental Disorders. So here's some of the information about substance use disorders that changed. Actually, I'm going to ask another question. Who here, are you all using the DSM-5? Are you using the DSM-5? Okay, no, not yet. And actually, you know what? A lot of places aren't using it. New York just started using it, and I was in New Jersey last week, and they're not using it. One of the reasons I think it's probably helpful, at some point, everybody will be using it. And so I'll just present some of the way that they call now or name some of the substance use disorders, and that's the term that's used. Remember, we always used to talk about substance abuse and substance dependence. Those terms have been changed or actually eliminated, and now the new term is substance use disorder. And one of the reasons that happened was that sometimes people got confused by the terms abuse and dependence, and also you can be dependent on a drug and not necessarily have an addiction to it. So for example, sometimes when people use painkillers, when they get off them and when they're taking them appropriately, they may experience withdrawal, but it doesn't mean they're going to end up in treatment. It does include 11 criteria. It rates the severity, and we'll go over those severity ratings fairly soon. Excuse me. They also added craving, and craving really they define as the desire to use the substance, and that is new. And one of the things about craving, if you talk to people who are in early recovery, often they are still craving or desiring to use the substance. So here's a question. Anyone ever go on a diet or try to give up sugar? Thank you. One of the reasons I use that as an example, because if you start to, let's say today is Tuesday, if tomorrow you decided you were going to give up sugar, then chances are on Thursday or Friday, guess what would happen? You'd probably have the desire to have sugar. And sometimes what will happen is that'll go away after a while. But for some of the people in recovery, they'll have that for up to 6 months. Sometimes they'll have it up to a year. And it can be a relapse trigger for some people. Another thing they took out of the DSM was the term legal. It used to be that the consistent examples were driving while intoxicated or other problems with the law. And so they took that out because they felt that the other criteria would work with it as well. So here's the criteria, and it really speaks to, in a sense, the duration in the same year, 2 or more. Use is longer and more over a period of time. And we'll go over the severity ratings after, but I'll present the 11 criteria. So 1 is use is longer and more over a period of time. 2 is unable to stop. Can anybody give me an example of a client who told you that they were unable to stop? What happened? It's a big one, where sometimes I could probably tell you. Oh, repeat the question. Yeah. The example on number 2 is unable to stop, and I was asking you if you ever worked with clients who told you things like, I went to that party, I was only going to have 1 beer. As soon as I drank 1 beer, I couldn't stop. I had to keep drinking and drinking and drinking until I couldn't drink anymore. Have people heard stories like that from clients? Yes. It may be difficult if I keep asking you all some open-ended questions, but so I may stick with some of the yes/no questions. 3 is substantial time using this substance, and if you ask somebody, how long did you spend copying or getting the drug, using the drug, or withdrawing from the drug, that you may get 80% of their time, 90% of the time, and sometimes that's while having a job. 4 is craving. 5 is failed roles at work or school, and what will happen is with that, what that means is that people, well, you probably know this, they don't show up for work, they get fired from their jobs, they don't go to school or they miss school, and those are some of the things that you might see. On the next slide, the criteria is continued. And you can see the picture of the alcohol and the car keys. 6 is social problems. 7 is decrease in activities, and sometimes people will tell you that they stop taking care of their children, or they stop going to work, or even hobbies, things that they used to like, they didn't do. 8 and 9 really deal with hazardous use, and hazardous use as examples such as driving while intoxicated, using machinery when under the use. The DSM-5 actually says swimming, which when I tell people in New York that, they kind of go, swimming? In New York, it's more driving, not so much driving, but probably walking while intoxicated. I sometimes tell the stories that I used to work, when I worked in treatment, I worked with a lot of guys who did construction, and sometimes people would drink and then use some of the like electric saws, or I also worked with people who drove the trains. And so probably when you come to New York and you get on the subway and they tell you that not to lean on the door. One guy told me a story about how when he leaned on the door, or when he was using, he would open the door on the wrong side. So moral of that story is, don't lean on the door. 9 is used despite physical problems. So sometimes somebody has HIV, they have hepatitis C, they have cirrhosis and continue to drink. And then 10 and 11 deal with some of the physiological responses like tolerance and withdrawal. So tolerance just means you need more and more of the drug to get the same effect. And withdrawal means that if you don't take the drug, you're going to get the opposite of the effects. So, for example, when people use heroin, it makes them feel very mellow. It takes away their anxiety. They feel very no pain. And yet, when they withdraw from it, they feel the opposite. So people will talk about feeling anxious. They'll talk about feeling a lot of pain, and they get almost flu-like symptoms. So those are the criteria for the new substance use disorder. They're really not all that different than the DSM-4 that we had. Again, no legal, but there is the craving. Now the severity, and for those of you who may be making referrals to treatment at some point, this is what they'll look at. They're going to look at the number of criteria, and if the person has 2 to 3, they'll have a mild substance use disorder, and they'll actually be very specific. So they'll say mild alcohol use disorder or mild heroin use disorder. You know, sometimes people say, well, I don't know if you can have a mild heroin use disorder. I don't know, could be. 4 to 5 is moderate, and 6+ is severe. So those are the kind of the new things around the diagnosis of substance use. There's 2 things that are not on the slide, by the way, and one of them is a new diagnosis called cannabis withdrawal. So, for example, a lot of times people used to tell me, oh, when you get off weed, you really don't have any withdrawal symptoms. But now in the DSM, they talk about changes in appetite, irritability, anxiety. And another one that's not my favorite is caffeine withdrawal. So that if you look at, for example, what happens when you get off coffee, the DSM says you'll probably have headaches, you'll be irritable, you won't be able to focus. When the DSM-6 comes out, here's what you might see. The internet gaming disorder. So I know people get nervous when I start talking about that, and also caffeine use disorder. So those are just some of the new pieces on substance use. Now, here's some famous people with mental illness, and if you take a look at that, you can see kind of a variety of people with different disorders. And you've got Jim Carrey talking about his bipolar disorder. Catherine Zeta-Jones, she has bipolar disorder also. Howie Mandel has OCD, obsessive compulsive disorder. Michelle Williams was treated for depression. And Brian Wilson has schizoaffective disorder, and he also is a person with co-occurring disorders because he also dealt with substance use disorders. So here, I have a question for you. What famous people can you think of who have had co-occurring disorders? They could be alive or dead. They could be from other centuries. So question, What famous people do you know of probably had co-occurring disorders? So if you just want to kind of yell that out, Charlie Sheen, yes. Robin Williams, yes. Whitney Houston, definitely. In fact, it's interesting because a lot of times with women as they're dealing with, and I know she was in treatment obviously for cocaine use, but probably was dealing with other abuse issues or depression, as was Robin Williams. Can you think of others? I do have a list of a couple of people, so I would say, actually, yeah, Michael Jackson, definitely. I would also say that Whitney Houston's daughter, who passed away this week, probably also had co-occurring disorders. Dennis Rodman, yeah, I don't know Dennis Rodman's background, although he probably does have a co-occurring disorder. I can throw out a few others. Amy Winehouse, if you like older musicians like Beethoven and Mozart. Robert Downey Jr. And for those of you who are baseball fans, and I didn't want to really pick a Texas team, but Josh Hamilton, who plays for the Texas Rangers, has been in and out of treatment, and it's really kind of fascinating. I've read his biography, and it's hard to figure out what happened. He was a really, really good baseball player early on. Like when he was 6 or 7, they knew he was going to be a really good baseball player. And when he was a teenager, he just didn't feel part of things. And he felt like happiest when he was at a tattoo parlor. And then he kept getting hurt a lot. And so, as you know, he struggled with, I know with cocaine addiction. I would say also he probably was, I don't know if he's been treated for depression, but he probably has a couple of other things. I think the neat thing is he seems to do much better in Texas than he did in Los Angeles. So we'll see what happens with that. But bottom line is it's really common, and again, it's almost the expectation rather than the exception. So mental disorder. So the mental disorders, I talked about substance use, and the mental disorders are one of the disorders listed in the DSM-5, and they range from mild to severe. So some people are dealing with mild depression, whereas other people are dealing with more severe ones like bipolar disorder or schizophrenia. These are some of the common combinations, and I mentioned this at the beginning, but substance use and depression is one of the most common ones, especially alcohol use and depression. Also, people tend to take drugs that mimic their illness. So if they're depressed, what do people take? Alcohol. If they have bipolar disorder and they feel manic-y a lot of times, what do they take? Cocaine. Substance use and post-traumatic stress disorder is also another piece, another common one, and I would guess that many of your clients are dealing with post-traumatic stress disorder. It may not have been diagnosed. In fact, next week we'll be doing trauma-informed care, and we'll talk more about that. You were saying, too, that you dealt with people who have schizophrenia, and it's interesting because often with people who have schizophrenia, the substances that are often used are alcohol and marijuana. Why? Because they're usually easier to get. If you're going to be addicted to heroin, you have to have some really strong skills in being able to have time management skills, budget planning skills. It's you're not going to see that a lot, although you may see that too. Now I have a question for you. When you look at the differences between men and women who are homeless, what do you think are some of the differences between men and women who are homeless and have co-occurring disorders? What do you think are some of the differences between men and women who are homeless and have co-occurring disorders? Might be a tough question, but I think y'all know the answer. So you can just brainstorm. There doesn't have to be a right or wrong answer. But when you look at the difference of the women at your site or the men, what do you see as some of the differences in terms of even their disorders? So I'll give you time to type it in. I won't sing or make any kind of music. Other guests usually take of the women. I don't know what that means exactly. So Other guests usually, oh, take more sympathy for women than the men. Ah, interesting. So that because of some of the gender differences, people might be more sympathetic, or could they be more empathetic? Yes, that makes sense. One of the things too, again, according to some of the research, and you can tell me if this is true or not, but often when men are homeless and have a mental disorder, it's often schizophrenia or, a severe psychotic disorder. For women, guess what? It's usually not schizophrenia, it's often depression. So however you want to work that out in terms of gender differences, but that's what some of the research says. So people always want to know, which came first, the chicken or the egg? Or what happened first? So you've got the picture of the chicken and the picture of the chicken in the egg. One of the things that happens is we're not always sure, and here's what we think. For many people, the trauma came first, usually early. A lot of times people are not diagnosed with trauma, or maybe people were neglected, they didn't have enough food to eat. And then following that, and I wrote substance use or mental disorder on the same because we really don't know what came first. It's sometimes, for example, the clients know, and they can tell you pretty specifically, and other times they don't. Also, sometimes people have multiple comorbidities or other disabilities that came first. And, for example, they may get HIV or hepatitis C or a traumatic brain injury, and then it follows the substance use or the mental illness. So I know everybody always likes to know what came first, but it's really difficult to identify which came first, and even if you do, it may not matter. Let me say too, though, it may matter to the client, and that's really important. The key is that all need to be treated. Okay, so here's going to do a case study, and let me tell you, I'll start to read it, and then one of the questions I'm going to ask you to type in is some of the things that you're concerned about meeting Thomas. So this is Thomas, and I'll read it. I'm Thomas, and I've been in your program for 6 weeks. I'm a small, thin man, and I used to work as a mechanic. I enlisted in the Army after 9/11. I wanted to give back to my country. I spent 2 years in Iraq. When I returned from Iraq, I couldn't cope. I kept thinking about seeing my buddies who were blown up in front of me. No one in my family understood what I was going through, and they were afraid of me. They didn't want me living with them. Sometimes I would hear voices tell me to do bad things. I also like to drink, and I find that alcohol makes me feel better at first. I eventually landed on the streets. I couldn't think of what else to do. I didn't like going to that VA hospital. Word on the streets in Dallas is that the bridge is a good place to go. I also heard you could get a free haircut there. That's not written there, but that's what I heard. I like watching the Dallas Cowboys, fixing people's cars, and helping others. So the question will be, and this is kind of a group thing, here's the question: what are some of the things you are concerned about after meeting Thomas? I'm going to go back to the case study so you can take a look at it. What are some of the issues that kind of stand out for you, or some of the warning signs? Right, PTSD, depression, substance abuse, anxiety, guilt. We have a whole variety of things. I think because I'm looking at the clock, and I'm going to skip over, and here's Thomas again, and you can see that there's different colors that are some of the warning signs that you might see. So first one, 2 years in Iraq, he couldn't cope, seeing his buddies blown up in front of me. I know that many of we've been working with some veterans here from Iraq and Afghanistan, and they all talk about having post-traumatic stress disorder. People often talk about their families being afraid of them, the voices telling him to do bad things. He likes to drink, and so those are some of the warning signs that you could look at. Now here's another question, or actually we don't get to a question yet, but when you look on treatment perspectives, sometimes people want to know, is it a substance abuse treatment that people are going to, or is it mental health? And it's one of our trainer answers are, it depends. What happens is that usually a lot of the substance abuse treatment programs will screen for mental health, and mental health programs will usually screen for substance abuse or substance use. So there's a lot of things. The key, by the way, is that obviously people get into the kind of the right treatment, and some of you may have the skills to do that, or actually I think you have some of the resources there that help with that. Now here's another write-in question, and here's what I'm going to ask you to do. When it comes to working with co-occurring disorders, what is your role? So some of you may be doing diagnosing, some of you may not at all. Some of you may just be talking to people and making referrals. So what are some of the things that you do around working with people with co-occurring disorders? So if people would type that in. Okay, so engagement, which again is a big one. Referrals, and that is another good one. Anything else? I'll go to the next slide. And I guess here's the key, is really to know some of your agency policies, know some of the local resources. Many of you are really good at that. To obtain documentation of clients' mental health and substance abuse history. One of the things that, we often do family histories of substance use. It's also helpful to document any kind of family history of mental health. Challenge is sometimes people have relatives who had mental health issues but didn't necessarily get treatment for that. Another thing that could happen, and I know actually the security guards, you guys could, and women, could do this as well, because sometimes you'll see what I would call red flags, and they're really warning signs. And because you often talk to people in probably more informal situations, you may be able to be very, very helpful to people about that. Another thing too is that sometimes it's helpful to talk with clients about the benefits of mental health services and or substance abuse treatment. And there's a kind of a knack of doing that. Culturally, a lot of times people don't want to go for mental health treatment, and you can't say to somebody, so would you like to see a psychiatrist or go to mental health? Because sometimes they'll say nope. But sometimes people figure out ways to do that, and to accompany clients to appointments when appropriate. So if that works for you and that's part of your job, I think that's something to think about. Now, we sometimes use this, stay in your lane. And what that means is that if you're not a doctor or a diagnoser, don't become one. And also just really kind of look at what are your skills, what are you supposed to do, what are you not supposed to do. Here's something that's like, I would say, what not to do. And do not diagnose or treat clients for any disorder unless you have the expertise to do so. Sometimes, for example, you can read the DSM-5 and it's easy to really diagnose people. I know when it comes out, or when I was in school studying some of the other DSMs, we would open up to pages and then we would look and see, oh, this describes people in my family, or this describes somebody I work with. So you've got to be careful about that. And working with doctors, they can really rule out any physical complications that might look like a mental health disorder. So for example, sometimes somebody might be on HIV meds and it may look like depression, and you looked in the DSM-5, and yet it just may be one of the side effects of the medication, or it could be a side effect of HIV. So some of you are looking for red flags, and what is a red flag? It's really a warning signal, and it's something that demands attention. The key sometimes is to look for changes. So here's some examples, and as I said, you really want to look for changes. So sometimes missing appointments or being late, changes in sleep pattern, sometimes people sleeping too much, sometimes people not sleeping at all, the deterioration of personal appearance, and that you may see as you work with people around personal appearance, maybe for a while they were getting better and then all of a sudden they're not. Sudden weight loss or gain, that's without a diet. Fatigue, panic, feelings of hopelessness, and suicidal ideation. And suicidal ideation is really something that's important to consider, so that when people talk about wanting to kill themselves, it's really important that some of you who have the skills to do a suicide assessment do that, or if you don't have the skills, to talk to somebody or make sure you refer or bring people down the hall to somebody who can do that. Now, there are some red flags that we would say require immediate attention. That object in the lower right-hand corner is a telephone, so depending on your age, some of you have never seen a phone like that, but in the old days, you used to have to dial it. You used to have to put your finger in one of those holes and dial, but I'm dating myself. Anyway, these are some things to look at. If somebody just has destructive behavior, you see, for example, somebody's throwing chairs at your site, that's obviously something that you want to deal with very quickly. Sudden changes in thinking capacity, disorientation. Sometimes people will not know kind of where they are, and probably in many of your cases when people come in, sometimes they are disoriented, again, depending on the substance or depending on the mental health. Sudden change in personality, a change in level of consciousness, signs of withdrawal, chest pain. Those are all 911, or make sure that the security guards are taking care of people around that. So here's, as we're starting to get to the end, what questions do you have on co-occurring disorders? This was really kind of a basic course that looked, as I said before, at substance use disorders, some of the mental disorders, some of the pieces around warning signs. So what questions do you have that I can answer as we start to close? Please type them in. Some of you know in Counseling 101, one of the challenges is that when you ask a question, you keep your mouth shut and give the people time to answer, because I can't see your faces or what's going on. Any questions I can answer before we leave? If one of the other disorders being treated, does it help the other disorder that's also diagnosed? Yes, sometimes it does. So if, for example, sometimes when people start going in, well, let me just give you some examples. Sometimes when people start going into drug treatment, sometimes actually the depression gets worse, especially if people aren't keeping track of it. Ultimately, it will get better, but it's one of those it depends answers, so that sometimes, as I said, things get worse, sometimes they get better. In fact, I used to work with clients who said, I don't get it, you know, I stopped drinking and now I can't get my head off the pillow. And one of the things to figure out is that, or to have doctors figure out, is what is is it real depression, or is it part of the withdrawal from alcohol? In an ideal world, somebody would be off the substance before they came up with a mental health diagnosis for about 3 weeks. That doesn't always happen, and that's why doctors will often give a few diagnoses at the beginning, and then they'll rule out. That's a term that's used a lot with figuring out, oh, well, we thought that he had depression, but he doesn't. Did that start to answer the question? No, that's a yes/no question. Or other questions? No other questions. And it did answer the question. Okay, then, I hope this was helpful. I really thank you for participating. Oh, hold on. I'm holding up. When you have a case that there is no improvement, what do we do? How do we continue if they don't want any help? That is a really good question, and I'll give you a couple of things. First of all, since you've had motivational interviewing, sometimes you can help people become motivated, or you can help people figure out where they are. one of the things that can happen is we can't always make people change. So if somebody says they don't want to go into treatment, let's say substance abuse treatment, you know, if you look at some of the stages of change and you talk to somebody about maybe the benefits of going into treatment and then kind of putting tape over your mouth, that can be helpful. It's really hard for example, if you think somebody should go to treatment and then tell them to go to AA or NA meetings and keep going, they're probably not going to do it. I think sometimes too you have to give people time, and I know from a client-centered approach, sometimes the best thing to do is ask them what do they want treatment for first and see what they say. And as I see it kind of at the end of the question is that sometimes people will not want any help. Usually, though, when people come to a place, there's something they're ready for. Sometimes we just have to help them figure out what they're ready for. And it may not be treatment for substance use or treatment for a mental disorder. They may want something else, and that may help them and then help you with engagement. And one of the challenges, too, with co-occurring disorders and mental health, at least with mental health, there's no cures for these disorders. And same thing, if you come from a disease model or a 12-step model of substance abuse, there's not a cure. There's treatment, and you do the best that you can, and then also have to let it go. And then probably chart that. Another thing that comes to mind, by the way, is that when you're talking to somebody is to say something using your words here about there's a case that there's no improvement. You know, you kind of want to look at what their treatment goals were. If their treatment goal, they said they wanted to stop drinking, then you can look at that from a counseling point of view and say something like, so it seemed like you said you wanted to stop drinking, and yet you are drinking. So I know that's developing discrepancy, but it really depends on what they said they wanted to do in the first place. Sometimes people set a goal and then realize it's not a goal that they really want to have. So sometimes you have to kind of go back and make baby steps. So I hope that was helpful. Other questions? Yes, thank you. No other questions. Well, thank you very much. I hope this was helpful. I really appreciate the fact that you were on this webinar from 9 p.m. to 10 p.m. Your time, and I will be back next week. We will be talking about trauma-informed care next week. So have a great week.